Today we welcome Dr. Christine Vaccaro to help us understand more about pelvic pain and to answer your question on what we can do to help women dealing with chronic pain. Pain is complicated. In an ideal world, it could be seen as our body's helpful warning system, signaling us to take action and seek treatment if we're injured or ill. Unfortunately, however, some people experience intense chronic pain without having any underlying medical condition, making this type of suffering all the more difficult to understand and manage effectively. Understanding and treating any type of chronic pain typically takes time, patience, and expert support. When pain occurs in the pelvis, an area of the body that's physically and emotionally complex, that's even more true.
Welcome to Sex Care is Self-Care, a conversation on women's sexual health brought to you by the Patty Brisbane Foundation for Women's Sexual Health. I'm your host, Patty Brisbane. Today we are talking about pelvic pain and the impact that this invisible condition has on women's lives, their relationships, and more. I'm joined today by a member of our PBF Medical Board, Dr. Christine Vaccaro. Dr. Vaccaro, I know what you do, and many of our listeners know what you do, but for those who are tuning in for the first time, tell them what it looks like for you on a daily basis. What do you do?
Well, hello, everyone, and Patty. I'm Christine Vaccaro, and just a quick little bio about me. I am a fellowship-trained and double board-certified urogynecologist and obstetrician-gynecologist. I'm currently the fellowship director for urogynecology and an associate professor of obstetrics and gynecology in Bethesda, Maryland. That's a lot of mouthful to say, what do I do on a daily basis? I treat women's pelvic floor disorders, including pelvic pain, which we're going to dive into, and to the nitty gritty. Back to you, Patty.
So let's start with our first question. Can you give our listeners an overview of what is pelvic pain and, what might bring pelvic pain on?
Well, first, Patty, I just want to thank you for opening the door to this topic. This is a topic near and dear to my heart. And from decades of seeing women suffer in silence, I'm really excited to talk with you today. Before I go into all the various details and all the various syndromes, I want to be clear on one specific thing, which is just because there's no outward signs doesn't mean the pain isn't just as real. I hear, sadly, from many patients that they've been told the pain is all in their head, and they get so discouraged they just don't come back. So I want to be clear, there's things that we can see on exam, and there's a lot of things we can't see on exam, but the pain is just as real and still needs adequate treatment. So to kind of get into the nuts and bolts, pelvic pain can be classified in many different ways. So it can be transient, meaning it comes and goes. It can be persistent, meaning it's constant. It can be provoked or worsened by exams or sometimes sexual penetration. Or it can be just completely constant without anything touching it or any inciting factors. It can be due to a disease process like endometriosis, an infection of the bladder, an infection of the uterus or cervix, or the tubes or ovaries. Or it can be more hidden, involving the nervous system, especially if that involves referred pain from another source in the pelvis, or potentially even something that we call central sensitization, which is a term that refers to how the brain interprets pain signals in the pain experience, which is kind of newish in the last couple decades about how pain is experienced. So I like to think about pelvic pain by system because it's not just one thing. I think when I ask medical students, about pelvic pain, they always jump to endometriosis, which is a very common pain condition, but there's so many other pain conditions. And I've seen lots of women have a full, hysterectomy, have their ovaries removed, et cetera, and they still have the pain because potentially a pain syndrome was missed. So when I do an exam, I think of it in systems. So I start on the outside with the vulva, then I examine the vagina, and then I examine the bladder, and then I examine the pelvic floor muscles, and then the cervix, then the uterus, and then the tubes and ovaries. And then I consider the upper tracts like the brain and the nervous system. I'll stop there. Back
That's,
to you.
you touched on something that I've heard so many women say. Like, I think that we as women know our bodies better than anybody else. And we know when we know something is wrong, we know something is wrong. And, we don't want to feel broken, but it's hard when you go in to see your doctor and they go, nothing's wrong. You're fine. I want I would like to create on our website some sort of checkoff list.
Hmm.
Meaning a checkoff list of saying you're not crazy if you're having this symptom, this symptom, this symptom, this symptom. It's time to see a doctor.
Hmm.
And if your doctor's not giving you the answers that you deserve, is it time to look for somebody else?
You hit the nail on the head there, Patty, but I will say the bottom line, really for me, it just boils down to one thing. So the checklist might be kind of small for me, because really nothing else matters. If it's bothersome and it affects the quality of life, it's time to see a physician. That is really the nuts and bolts of it. It's that simple. But to break it down further, if you're, all symptoms usually become bothersome. But as far as pain, I see pain in a few different realms. There's the pain with sex realm. There's the pain with menstruation realm, pain with urination, pain related to an infection. And then there's the patients that are almost, when they come to me, they're pelvic cripples, which what I mean by that is they've been in so much pain for so long, it's become so chronic, and they've become so discouraged by not getting an answer, that because no diagnosis has been made, that they're in a whole separate category and require usually a multidisciplinary approach.
Okay.
But let me, yep, go
Yeah,
ahead.
explain that.
I'm gonna talk about first the pain with sex, because I think that's one of the realms I see a lot. And what I would tell women who are listening is it's really helpful for physicians if you can help us by describing the pain. So I usually ask my patients, do you experience pain with initial penetration? Do you experience pain with deep penetration? Do you have pain that lingers after sex or causes vulvar or bladder pain even hours or maybe even days after sex? When's the last time you had sex? For some women that have significant pain, it's been months or years. And that gives me an idea of the severity. And then really for us, we're basically like Sherlock Holmes, right? We have to know all the details, and the symptoms are the best clues we have to diagnose what's going on and how best we as clinicians can tailor therapy. So I can't emphasize that enough. There's other things like what makes it better, what makes it worse. Those are usually also very helpful. So in discussing pain with menstruation, again, it's really helpful in describing the pain. Has anything helped? Heating pads, exercise, medications, menstrual suppression, potentially with continuous hormones. And then again, anything make the pain worse, such as engaging in sexual activity or other stressors. And one I'll hit on a few times is poor sleep hygiene. So Americans have very poor sleep quality due to devices and lots of reasons. And that can also affect the pain experience. So I also talk to my patients about their sleep and other stressors that flare pelvic pain. And then another thing I see commonly as a urogynecologist, I deal with a lot of urination problems. So after I rule out a bladder infection, the next most common thing is a condition called bladder pain syndrome, which is also known as interstitial cystitis, which is an older term. But this is a condition that, again, affects many of my patients. They describe going to the bathroom very frequently during the day, sometimes upward as every 15 minutes. And then frequently at night. I've had patients up 5, 6, 7 times at night, which, again, really harms their sleep quality and their ability to deal with anything in general. And this can be going on for, years and years. So I always, like to think about when I was getting poor sleep with newborns and imagine how that would be for decades. And that's what a lot of these patients have gone through. It's exhausting. Typically these patients tell me that the symptoms are worse with acidic foods like coffee and citrus acid. Those are the most common triggers. And also the pain increases with sex, any kind of sexual penetration, any kind of extra stress, financial, marital, etc. And I want to make sure this is clear. This syndrome is often misdiagnosed as a bladder infection, and this can be misdiagnosed for years and years and years. And part of that reason is that we standardly, in standard practice, give an antibiotic with a medication that numbs the bladder. This medication is commonly known as pyridium or azo. It's over the counter. And the active ingredient is phenoazopyridine. And this turns the urine orange and it numbs the bladder. So patients, when they get the antibiotics and this numbing pill, feel better because the numbing pill helps their bladder pain. And so this creates the idea that this is the correct treatment. So that it was a bladder infection because I'm getting better. And again, the cycle just continues and they come in every few weeks to their doctor getting the same treatment, where really it's just the numbing pill that's actually helping them. I've had patients misdiagnosed for decades because bladder infections are common, right? Everyone's heard of a bladder infection, commonly associated with urinary urgency frequency. So again, it gets overlooked, which is very unfortunate. And then next category is infection. So, and I'm just going to go into another unfortunate circumstance, which is patients that get chronic antibiotics for bladder infections when potentially it's not a bladder infection, and they get a disruption of their normal vaginal pH, caused by an imbalance of the healthy bacteria in the vagina, and then they get a yeast infection. So this is the worst, right? We've not even treated the right condition, and then we're causing another quality life problem that then requires more treatments. And then they kind of just bounce back and forth with these yeast infections or another infection called bacterial vaginosis, which is overgrowth, again, based on an imbalance of the pH. And these vaginal infections are super common. They're associated with heavy discharge and significant inflammation of the vulva and vagina. Other infections that we commonly encounter, anything related to sexually transmitted diseases of the cervix, uterus, tubes, or ovaries. But lastly, I don't want to say that bladder infections never happen. They do happen, and actually they are very common. 40% of women will experience a bladder infection in their lifetime. But again, usually this type of condition is treated, the symptoms go away and don't come right back. And then I think the harder topic is, again, what you probably want to talk more about, which is the chronic pain patient that has been not listened to or heard for a very long time. These patients usually have coexisting pain syndromes. And again, they've had the pain so long that it becomes hard to even quantify or characterize. They just basically tell me everything hurts, and I try to get them to tell me any descriptors. And again, the whole entire pelvis has now been sensitized to the pain, and it's very hard for them, even with a systematic exam, to really pinpoint the location. So this really requires a very astute clinician, and again, a very systematic pain mapping exam in hopes of finding the primary source of pain. Sometimes you can't find the primary source. And just to be clear, I'll walk you through my exam just to illustrate how to do a systematic evaluation. So first, I start on the outside of the vulva, and I use a cotton swab to lightly touch around the opening at the vagina called the vulvar vestibule, which is a very hormone-sensitive area and a very specific area that can be a cause of pain with initial penetration. And then I assess for vaginal dryness or discharge. And then with a gentle one-finger exam in the vagina, I feel the bladder, and then I feel the pelvic floor muscles, and then the cervix, and then the uterus, and lastly, the ovaries and tubes. And almost always, I find more than one pain syndrome. And all areas that are painful will need treatment. And again, it's most common for me to diagnose multiple pain syndromes. It's less common for me, again, I am a subspecialist though, it's less common for me to diagnose only one pain syndrome, unless it's just something that has recently come up. And just to illustrate this in a patient that I recently saw, she had been referred to me from a pelvic floor physical therapist who had been treating her pelvic pain for about a year. And on exam, she had primarily vulvar pain syndrome, which sometimes is referred to as vestibulodynia. And that was causing her pelvic floor muscles to spasm, which leads to the muscles of the pelvic floor being painful. So sometimes to help patients understand the pelvic floor, the diaphragm, which is kind of a hard muscle to think about, I try to use an analogy about an injury to the spinal cord or the spine. So like a neck or a back injury. So when you have a neck or a back injury, what happens over time is everything just starts to tense up and guards the area of injury. And that's what happens in the pelvis as well. So if there's an area of injury, some trauma, something, childbirth, sexual trauma, etc., over time, the muscles just are guarding to protect that area. And then over time, the muscles themselves become painful. Sometimes our body overcompensates for pain. And this is also hard to reverse that. And first, it starts with treating the primary area of pain and then continue down the secondary areas of pain. But for this patient who has primary vulvar pain, treating her pelvic floor muscles might have been helpful, but if we don't address her primary pain area, she's never going to get better. So again, traumatic injuries, birth injuries, sexual or physical trauma injuries can cause just sensitization, and they can manifest as pain, even though sometimes we can't actually see an area that is classically, there's an infection or there's a mass or something, right? Sometimes we can't see the pain. That doesn't mean it's not there. These long-term chronic pain patients almost always need a multidisciplinary team approach consisting of a physician, a behavioral health provider, a pelvic floor physical therapist, and usually a pain specialist, either a psychologist or a pain medicine doctor. Whew, that was a lot, but I had to get that all out there.
I like that. So it's a tribe. You need your tribe.
It's a huge tribe.
Yes.
It's a huge tribe. Absolutely. Absolutely.
And I like hearing that, because I think that it's important to know that it's just not going to be one doctor that's going to solve this. You need to be prepared to have many, the tribe.
Absolutely.
Yeah. So are people such as that have autoimmune, or they've gone through cancer, or who's the most susceptible to pelvic pain? Is there any one particular?
Yeah, and no one's excluded from this, sadly, but certainly there are women that are a little bit more prone to pelvic pain conditions. And again, I like to sort of think about this in different categories. So first, you mentioned cancer. So patients that have had treatment for, let's say, breast cancer, which is super common, sadly affects 1 in 8 women. Get your mammogram if you're over 40. But this affects the vagina, right? So most treatments for breast cancer cause vaginal dryness, which then in turn can cause pain with sex. Sometimes other pelvic cancers that require surgery or radiation to the pelvis then can change the anatomy of the vagina, making it too small or lose its stretchability. So it becomes very kind of rigid, and that causes pain with penetration as well. You mentioned autoimmune conditions. So again, I kind of put this in the bucket of skin conditions of the vulva and vagina. So anything from menopause to, again, radiation changes as well. But again, menopause causes dryness due to loss of the estrogen support of the vagina. And then there's other things like lichen sclerosis, which I want to commend you that we have an ongoing study looking at new treatments for this that the Patty Brisbane Foundation has funded. So thank you, Patty.
Oh, thank you.
But this is a really exciting new area of treatment for this autoimmune skin condition that causes severe itching, burning, and tearing of the vulvar tissues, which again surround the opening of the vagina. Very distressing, very bothersome, and certainly affects sexual health. And then lastly, patients that have other chronic pain syndromes. So these classic pain syndromes that I see my patients that have the more chronic or complex pain syndromes, they usually have coexisting diagnoses of fibromyalgia, migraine headaches, irritable bowel syndrome, and depression. Also, patients that have had multiple adverse childhood experiences, such as witnessing or experiencing any trauma or repetitive trauma in childhood, usually also tend to have more chronic pain syndromes, including specifically pelvic pain. And then just something about depression. So we know that depression is highly associated with chronic pain, but it's not clear if it's the chicken or the egg, what came first. We just know that it certainly is highly correlated, likely because it affects quality of life. Back to you.
So, when is it that a woman needs to see a physician? When is it that she goes, okay, I'm done, I've got to go see? And does she start with her gynecologist? Does she move right on to a urogynecologist? Tell me, does she go to her family physician? Where does one start? So she's not seeing 17 doctors.
Yeah, that is an excellent question, and it's going to be tailored to the individual. But to answer your first question, if it is bothersome or affects quality of life, it's definitely time to see a physician. Which physician you see is going to be highly variable based on where you live, what kind of resources you have, who if you've had an OBGYN that you love and you have a good relationship with, I would start there. If you're in a really small town, I remember as a med student working in a town of 4,000 and there was only 2 family docs. That's all you got. So it really kind of depends on, who is available. But certainly if whoever you know well doesn't give you the right answers, just prepare yourself to see more than one physician. A lot of times it takes a few different physicians to get down the road to recovery and relearning and returning to your full quality life. But please hear me, don't ever settle for the line, it's all in your head. Please don't stop there. You just need to find another physician. You need to break up with that physician and you need to find another physician. And this is where sometimes talking to your friends, your family members, seeking out other advice from other sources that can lead you in the right direction to find a doctor that is equipped at treating pelvic pain. And certainly urogynecology is a great place, but not all pelvic pain needs some specialists to start with. But certainly I tend to see the more complex patients that there's been not a great diagnosis yet made.
Okay. Okay, so let's talk about what are the challenges that patients face throughout the diagnosis and the treatment process.
So again, this can take years, which is very sad and unfortunate, but I just want to set expectations because again, various providers, a lot of trial and error. Pain is so individualized. There's so many different tools we have, but not every tool is right for every patient. Additionally, just a general rule of thumb is the longer the pain's been present, the longer it takes to cause significant improvement. And we know now that chronic pain medications like the opioid narcotic type of pain medications actually make chronic pain worse over time. So unfortunately, this is not something that can be cured by one medication like a pain medication. In fact, again, that makes it worse. Usually this requires a multi-pronged approach with more than one provider. And again, it also relies on the patient to do a little bit of self-help, such as, again, getting great sleep, great amount and quality of sleep, and then trying to reduce, which is very hard, other stressors in their lives, like financial, marital, family stressors, to be in the best place possible to improve their pain. Also, I tell patients that setbacks should be expected, just like every day can't be the best day ever, and there's no stress and everything's wonderful and your kids let you sleep all night and et cetera, et cetera. So just expect setbacks. And just know that with continued treatment, things generally get better. Another just thing I want to mention, which is very disheartening to patients that I hear a lot, is that they get conflicting information from providers. And my best advice for this is to trust your gut. Go with the provider that you feel gives you the best recommendations and best advice. Do a little bit of research on your own. I don't recommend going straight to Dr. Google, but I do recommend going to websites that are very reputable, like WebMD. The Mayo Clinic has nice information. Your site obviously has nice information at the PBF, but make sure you're going to a reputable source. And then don't be afraid to ask questions and advocate for yourself. I think too often patients sit back and they get a lot of potentially talking from the physician, but they don't speak up enough to advocate for themselves when something's not working or if they weren't heard appropriately. Sometimes it's helpful to keep a journal of what's worked and what hasn't worked so that you can quickly lay out for a physician like, hey, I've tried all these things, these didn't work, which is really a great clue for us. So then we can try other things that are newer or in a different category or a different therapy class. And again, don't give up hope. Just, again, if you haven't connected with the right provider, you just need to continue searching for a provider that will help you.
That's great advice. It really is, because don't give up. So now we've talked about the challenges that patients face. What are the challenges that doctors face when providing treatment for helping women with pelvic pain?
Yeah. We always say that there's not enough time, right, in the day. Like we could extend, the 24-hour to much longer day, but it's really the time. So for a provider, it takes time to take a good history from a patient. It takes time to do a thorough exam. It takes time to review all the medical records, review all the treatment options, and provide education to the patient. So, and a lot of physicians are, given very little time to see patients. So what I try to set the expectation is that this will usually need several visits. It's not probably going to be everything addressed in one visit because, again, it didn't take, it took probably several years to get to this problem. We're going to need to take it in little bits and pieces. So I think as providers, if we set the expectations clearly for the patient, that is helpful. Additionally, I think it's hard sometimes for providers, and it can be a little bit taxing if the patients are, and this is no fault of the patient, but they've never been listened to, they haven't been heard, they've been told it's all in their head, and they're kind of preparing to hear that again. And it's hard sometimes as a provider to talk them out of that and say, no, like, you're in the right spot. We're going to help you. Yeah. But sometimes it takes a bit for them to realize they're not going to get turned away again or told that there's nothing wrong. These patients, in my experience, usually have significant anxiety also with anticipated pain during exams. So sometimes, again, just to be able to do an exam may take a few visits to get them comfortable with you, to be able to actually do an exam. So these are some of the challenges that physicians face. I would say, again, time is probably the biggest.
I think that we need to know that it does take time, that it's not going to happen overnight. It's not going to be like running through McDonald's or a drive-through right. and getting that immediate.
Yeah, I mean, I think we're in a society where we just want it now, right? It's like you can stream anything, you can do anything. Like you can go through the fast food, you can whatever. This is something that it's not a fast process, but generally is a continued progress towards getting back to full quality life as long as the patient continues to come back.
I'm going to ask a question that you were not prepared for.
Okay.
But I know you will give me this. How important is it for us to have more information for our doctors to be able to take care of us? More research.
And I'm guessing More research. Yeah. So again, one of my fellows, I'll just talk about her research, did a research study on bladder pain syndrome. And when she was presenting this as her thesis work, everyone was shocked that she did a research study on pain, because most clinicians and researchers shy away from doing pain research because the patients are usually very, I hate to use the term, but needy, and usually require a lot of frequent phone calls, frequent check-ins, and a lot of clinicians just don't want to have that kind of clientele. So number one, I'm very proud of my fellow for doing this study, but we clearly do not have enough research on pelvic pain syndromes. There's so much more work that can be done. I'm grateful that there's a whole specialty, though, of medicine called pain medicine that any provider can go into, whether that's anesthesia, general physicians can go into that specialty. So there are different research being done on pain in general, but I think pelvic pain specifically still has a long ways to go. But I appreciate all the support you always give for pelvic pain conditions.
I think it's so important for our doctors to have this research, because it is it's going to be needed. I was always taught to leave this world a better place than what I found it. And in working with so many women over the years, we always place ourselves on the back burner. We take care of everybody else's needs, wants, desires, you name it. We're all we go, and we take care of everybody else. It's time now, especially as I look at my granddaughters. I want to make sure that they're not going to go to 17 doctors to get answers.
Right.
And I've dealt with one of the granddaughters who, has had a lot of pelvic pain with endometriosis. And it's really a hard thing to watch. And when she did finally find the right doctors, thanks to our board, she cried in the room. And I cried, because I don't want to see any woman deal with that. I don't think it's right. I don't think it's fair. And I want to see more research, so you guys have the opportunity to help women through pelvic pain disorders.
I support that 100%, 110%.
I know.
For sure.
Can we talk about the ways and the ways that we can heal from chronic pain? Can you touch base on who are some of those other people out there that might help?
So here's like the hope and the good news. This is the part that gets exciting, especially for patients that have been told that maybe there's not a lot that can be done. There's a ton that can be done. Multidisciplinary teams, though, are going to be critical for the complex pain patients that have had pelvic pain for years, if not decades. In my practice, my team consists of pelvic floor physical therapists, women's health psychologists, ASEC certified sexual health and intimacy counselors, and pain medicine providers, which include psychologists and pain medicine physicians with special training in different types of pain management. Each of these providers has their own specialized set of tools to help patients. But the cool part is, if you have this sort of multi-pronged approach, generally with medicine, the more ways we sort of attack things, the more easily we can nibble away at the pain from multiple different angles. So I find that if we can engage more than one provider, specifically several, the pain gets better much quicker. The really cool part too about this group that I work with is we meet multiple times a year to discuss our complex patients that really either, figure out what else we can do for them if they're not improving. But very briefly, pelvic floor physical therapists, they do myofascial release of the pelvic floor muscles through internal massage and sometimes biofeedback, which allows the patients to learn how to relax the pelvic floor if they have a lot of tension in the pelvic floor. They have other specialized therapies that they use, dilators and other wands to help target a specific area of the pelvic floor. They also do a lot of work figuring out the how the patients walk to make sure it's not another musculoskeletal problem that's affecting the pelvis. They're absolutely fabulous, and I couldn't live without them. Next is my women's health psychologist. She is amazing. She really gets at the things that I probably don't have enough time to talk to the patient about, like their marriage, their finances, their children, their other stressors in their family, their work stressors, all the things that just kind of their sleep history, all the things that kind of play into how their pain is experienced. And then our ASEC certified sexual health and intimacy counselors, these people are also amazing. So usually they like to meet with the patient and individually at first. And then once the patient and the provider feel comfortable, then bring in the significant other, which is the really critical part as well for healing and understanding. And then lastly, there's a specialized form of psychology called pain psychology. And these very, again, specialized psychologists educate patients in the experience of pain through lots of different and various avenues to help them understand the pain experience, which is, similar to the phantom limb where, a limb is lost, but the pain is still there because it's more experienced in the brain than actually in the limb. So they do a lot of other education for the patient, help understand pain. And then lastly, the pain medicine specialists, I think, are super cool. They do all sorts of different nerve stimulators for specific areas to help block or modulate the pain response. So very, very cool stuff that and they can do blocks and other things to help patients with pain and help also sometimes diagnose the actual nerve or area of the etiology of the pain.
So again, we're back to the tribe, right?
That's right. You got to have your tribe for sure. 100%.
There you go. So being in the business, owning Pure Romance, working with, thousands and thousands of women, I've had many women who have come to me that is experiencing pelvic pain, and they don't know how to talk to their significant others about this. There's shame, involved. There's like, he's never going to believe me. He thinks that I'm interested in somebody else. How do we help her? How is it? What do you do? How do you start this conversation?
This I hate when this happens because I often have the patient telling me that her husband's about to leave her, because maybe they haven't had sex in a very prolonged period of time. And just like you said, Patty, the spouse thinks that there's an affair or that they don't like, they don't like their spouse, etc. So for me, what I try to do, number one is normalize that she does have pain. And then I try to get her to bring her significant other in and include them. If she's okay with it, I include them in the exam as I'm discussing what areas of the pelvis I'm examining, for them to hold the patient's hand while he can, or the significant other can appreciate the areas that are tender. And then I also have the significant other in the discussion. I often use a very simple analogy because I'm a simple person and sometimes analogies are helpful. And I ask the significant other if they've ever burned themselves on a hot stove. And most people say yes. And I said, well, how many times do you want to burn yourself on the hot stove? And they're like, well, never again. And I just use this simple analogy to have them sort of experience what the patient's probably feeling, which can be anything from obviously a pain burning sensation to a pain pressure sensation to a shooting pain sensation. All of those, again, are very negative experiences that most people don't want to experience again when it's significantly painful. And usually when the significant other understands that, it's not that they aren't loved or they're not appreciated. it's pain, even though they might not be able to see the pain, like a broken limb or something. It's still present, and it's just as real as pain that we can obviously see. And I love to get them and get into the sexual health and intimacy counselors as soon as possible. I find that's the biggest step in rebuilding a relationship and moving forward.
I love how you do that with your patient and with their significant other, because I think that does give them a better understanding of what's going on with her and why she's feeling. And I think bringing that, him in or her in, to know that it's not about them. It's really truly about the pain that they're going through. And it isn't anything. It's not like you have a burn that you can actually see. So I think that that's so important. Can you talk about how many women are affected with pelvic pain?
Of course, in my patient population, it's almost everyone, but in the general population, it's about 1 in 7 that will experience a pelvic pain condition in their lifetime. Hopefully those conditions improve with treatment, but some are lifelong. But it's quite a significant amount of patients.
1 in 7, that might seem like not a whole lot, but it's out there. And I know that I hope women can have this conversation not only with their significant other, but even with their friend group, and open up the conversation, because so many women feel like when they're experiencing pelvic pain, they're broken, and they don't know who in your group that you might be having dinner with might be going through the same thing, and people will not feel so alone and feel so much shame. And I've brought that up with many friend groups before, and I think it's great to get it out and to be able to discuss it and open up and not feel like you're really truly broken, because it can be fixed. You just got to find the right tribe to help you get through it, both you and your significant other.
And I love that we're doing this podcast, because it just, again, normalizes how many women this affects, and hopefully gives them, or anyone that's listening, the motivation to reach out again with a provider. Because it is 1 in 7. It's very common.
Is there any online that our listeners can go to and learn more about pelvic pain?
There is, and I'm not well versed in it, but there is an international vulvovaginal pain group that I'm sure can be Googled. I'm sorry, I don't have the website right off the top of my head, but that's one resource. And then I refer patients to National Vulvodynia Association.org. It's NVA.org for information on vulvar pain syndromes. As far as bladder pain syndromes, I usually go to the AUGS website. It's augs.org. And there's lots of patient education flyers under the Voices for Pelvic Floor website. It's voicesforpfd.org, actually. And there's lots of information there as well about bladder pain syndrome. I don't have a great resource for endometriosis, but I'm sure the Mayo Clinic or WebMD has lots on that topic.
I don't want to... Go ahead.
And then lastly, the apta.org, which is the Physical Therapy Association, would probably have a lot of information on musculoskeletal pelvic pain related to the pelvic floor muscles.
We can also put some of those sites up on the Patty Brisbane Foundation.
I think that would be great. If we could just make a little list, and I'm happy to send them to you, so that based on the specific sort of area that the patient probably realizes that they may be having symptoms, could research on their own to have more information when they go into their provider.
Before I close, I don't want to slap Band-Aids on anything because I'm not that person. But also I want to talk about a little bit about when you are going through pain disorders or it's uncomfortable, that there are other ways that you can make each other feel needed, loved, wanted. And sometimes it's just as simple as if you're experiencing whatever type of pain, of using a good lubricant. A lot of women will not use a lubricant because they think, again, oh, if I use a lubricant, he's going to think something's wrong with me. I'm not interested in him. You know, when we're under stress, when we're taking medications, sometimes we don't produce our own natural lubrications, and we need it. And we know that women achieve better results when using a lubricant. Also, giving each other a nice massage in the bedroom.
Yes.
I think how do you feel about?
Yeah, I really appreciate you bringing this up. I think this is a huge topic. I've seen it both ways. I've seen the patient that you're talking about that feels broken and feels like they should always be instantly ready, you know, with absolutely zero foreplay. So those patients, I generally do recommend a lubricant too. I've also seen the flip side where I have patients that will come to me and say, well, all my provider would ever say is just use a lube. And certainly that's not the cure-all for all pelvic pain conditions. But don't get me wrong, lubricants are especially helpful for women with vaginal dryness. And I often recommend a hybrid silicone water-based lubricant for those patients. And then, of course, other lubricants can enhance sexual sensation. But when there's a non-dryness related pain condition, it really requires medical attention from a multidisciplinary team. We also know that some lubricants can, especially the heighteners, that can cause more tingly sensation. Those, especially for patients with vulvar pain syndromes like vulvodynia, actually really make their pain worse. So we do have to also be careful about which lubricants patients with any kind of pain syndrome should use. And then I love that you brought up the massage, because I think all too often men and women think that intimacy is only vaginal penile penetration or penetration of some sort. And there's so many other forms of intimacy that don't involve penetration. And as you know from research that was done with Pure Romance products, for a woman, the clitoris is really the main sexual end organ, and women really love clitoral stimulation because, as we've discussed in other podcasts, the female clitoris and the female urethra is immediately analogous to the male penis. So the vagina for women sometimes is not a great source of sexual pleasure. And if it's causing pain, we need to explore other avenues with our partner. Again, it doesn't even have to be the clitoris or the penis. It can be just other forms of intimacy, kissing, massage, etc., that just produce that feeling of intimacy and closeness between a couple.
I think it's just important for the couple to have that conversation and connect. And it might not be right for them, but I also want people out there to know that there are other ways than having penetration. Do you have anything else that I neglected to ask that you might want to bring up?
I think we did pretty comprehensive, but the one thing, there's two things I really want to just hammer home one more time is, one, pain is not in your head, meaning there is always, if there's a pain syndrome of any sort and it's affecting your quality of life in any way, please seek help. And if you don't get the right answers, continue to seek help. And again, I'm going to send you these websites that we can direct people to, but there's lots of resources. There's great clinicians, but sometimes you have to do a little bit of searching.
Thank you. I want to thank my guest, Dr. Christine Vaccaro, for a great conversation. And if you like what you heard today, please rate and subscribe to our podcast. For more information on the Patty Brisbane Foundation for Women's Sexual Health and our focus areas, visit thepattybrisbanefoundation.org. Remember, sex care is self-care and sexual health matters.